Hi, class. This is your review for Exam 3. Exam 3 will contain questions on mood disorders. That includes anger, aggression, suicide, grief, and loss, bipolar disorder, eating disorders, mental health across the lifespan, and I, as promised, have added the questions on somatoform disorders. Okay, let's get into the review. Let's talk about somatic symptoms for a moment. Remember that with somatic symptoms, there's no physical cause. So, mental distress is causing the symptoms, and the patient is not controlling this. Okay, this is not malingering, this is not manipulative. This is, for instance, sometimes before an exam, people feel nervous and get diarrhea. Sometimes people feel nauseous. Sometimes when students have a big presentation the next day, and I mean like younger students, grammar school or something, they feel nauseous or they wake up with a headache. That's all stress, and that's not anything you're controlling. And the symptoms are quite real, right? The diarrhea is real and the nausea is real. So, somatoform disorders, this is a chronic thing. So, the chronic back pain or chronic headaches that are specifically due to stress or anxiety or trauma. So, mental distress is causing the symptoms. And often the clients or patients are convinced that there's a larger physical issue. Like, I have a terrible headache, I must have a brain tumor, something like that. So there are conditions, there are physical illnesses that can be worsened by psychosomatic symptoms, namely stress. So these are going to be the illnesses of soft tissue, not of bones. So diabetes, hypertension, headaches, colitis, all of those can be worsened by stress and by psychosomatic symptoms. Things like arthritis will not. The pain could be, but the condition is generally, bone conditions are not worsened by stress. But all of those organ tissues absolutely can be. So, somatic symptom illnesses are stress that's internalized, as I said. So, it's internalization of psychiatric stress that's causing the physical symptoms. And, do remember that the pain is real. I just said this, but I really want to impress this. So when a patient tells you, that there's these symptoms and you know that stress is causing it, again, the symptoms are real. Think about your own stress and when that has led to a physical discomfort, again, like diarrhea or nausea or a headache, those symptoms are very real. So be sure to validate what patients are saying. If the patient says, hey, I have a really bad headache, I know it's stress related, the nurse's response is going to be that pain is very real, and acknowledge that. You're not going to brush it off because you know it's psychosomatic. Now, when people control those complaints, that is called malingering. For instance, we often see this in people who are going to be discharged back to prison. Maybe they've come from prison because they're depressed, and then they state a physical complaint like severe head pain or something, but they're not actually having head pain. So when they're not telling the truth and they're sort of creating this story in order for in order to gain something like continued stay. Maybe they don't want to go back to prison. It's much more comfortable in a psych facility. So they will create a scenario so that their discharge will be delayed. And I'm not saying that all people do that, but that is something that we see. Or maybe I'm from the Northeast, so we would see that homeless people would come in with a lot of complaints on a very snowy night. That is malingering, to make up a story in order to be admitted or can have continued stay or maybe gain financial benefits. That's malingering. So, speaking of malingering and manipulating situations, Munchausen is when you're manipulating a situation uh, for physical attention. Um, I had a patient in Florida who went from emergency room to emergency room all across the state, complaining of very serious cardiac issues, and went through a lot of cardiac testing just to get pain medications and the attention that comes with a cardiac issue. Munchausen syndrome by proxy is that you are doing this to someone else. And so you will see this, you will see a parent, often the mother, doing this with a child. So mom brings the child to the emergency room saying, oh no, my baby is sick, and they get a lot of attention, but the baby is not sick, or maybe mom made the baby sick for that attention. That is Munchausen syndrome by proxy. Very dangerous. And it is a variation of factitious disorder. If you think of the word factitious, that's something made up. All right. Illness anxiety disorder. It also falls in this umbrella. And it's a preoccupation with the fear that you have a serious disease or will get a serious disease. Clients misinterpret pain, sensation, or condition. For instance, let's go back to the person feeling nervous who gets diarrhea. And then let's say that person is obsessed with the fact that they have diarrhea and think that now they have an abdominal condition, like, I don't know, colitis or irritable bowel or something. And they will diagnose themselves and they will find information on the internet. They will go to doctor after doctor after doctor because they are absolutely convinced that there's a larger issue. That's illness anxiety disorder, just like it sounds. The person is having anxiety that they might have an illness. And they really focus on this and talk themselves into it. Okay, let's see. How do you know when a patient has somatoform disorder versus a physical disorder? Well, first of all, we take the patient's statements very seriously and rule out all physical disorders. And also, we listen for statements that will connect the physical disorder to an emotional happening. If somebody says, I seem to have more pain since I'm going through this divorce, or since my loved one died. So when you hear that connection between pain and the physical, or pain and the life issue, that is sort of a red flag that there could be somatoform disorder. Could be. Now, remember that these symptoms can also make the symptoms of actual illnesses worse. So let's say you have migraine headaches, and you go through something very stressful, let's say like loss of a job, and say, since I lost my job, my headaches are so much worse. Well, you still actually have migraines, and this current head series of headaches is probably caused by the stress of losing the job. I hope that makes sense. So there can be a real disorder, and the somatoform disorder can make that worse. All related to internalization of psychological issues. Okay, remember that when a question asks for which of the following statements would indicate that the patient needs additional teaching, that means you're looking for the statement that is incorrect. So if you have 4 choices, 3 statements will be correct, 1 statement will be incorrect. So think about that. If the question asks, which of the following indicates the patient understands the teaching, then you're looking for the correct answer. You'll have 3 incorrect and 1 correct. Don't let your eye fall to the answer that you know is correct that you recognize first. Read the question carefully. So, going back to somatization disorder, clients often have sleep pattern disturbance, and very often don't exercise because they're in pain. They're having pain. They might be taking prescriptions for pain. So you want to provide education about limiting caffeine. Caffeine will not help. Neither will nicotine and other central nervous system stimulants. Those substances can increase physical symptoms of anxiety. Remember that rapid heart rate, feeling jittery. Caffeine and nicotine are going to increase those symptoms. So we don't want the patients with somatoform disorder to have those substances. So if a patient says, I'm going to drink more coffee, that indicates they need additional teaching. Let's see. I'm just reviewing my notes as I'm talking to you. Let's see. So clients with hypochondriasis, you want to review that word. They are convinced that they have a serious problem despite all negative results. So you might hear the client say, I know the x-ray of my back was negative. I know the CT scan was negative. I know I've seen these 5 doctors and they all say there's nothing wrong, but I know I have something wrong with my back. They're absolutely convinced, and there's no telling them otherwise. They will go from doctor to doctor constantly until they get the answer they're looking for. So you want to acknowledge the client's frustrations, because the clients are frustrated. They don't want to have to go from doctor to doctor, and it's not that they like what's going on. They really believe that they're ill, and they'll go to a doctor and just not hear what they're looking for and think, okay, well, this is not the doctor for me, I'll go to someone else. Now, this is difficult because that actually does happen. I want to acknowledge that there are those situations when people go to a doctor and that's not the doctor for them. And yes, doctors do miss things. But I'm talking about this chronic behavior over months or years, and it'll be a lot of doctors. We're not talking about 2 or 3. We're talking about 10 to 20 doctors, frequently doctor shopping, frequently hopping from doctor to doctor, and unable to maintain basic life events like keeping a job, keeping relationships because they're so focused on going to the doctor all the time. It's really difficult for them to maintain relationships. That's hypochondriasis. Okay, so let's talk about depression. One of the most popular antidepressants is Prozac. You should know the generic and the trade names for the medications that are talked about throughout this course. So fluoxetine is Prozac, excuse me. And it does have some side effects. It's a very common drug. It has very little side effects, but it does have a significant side effect, and that's a decrease in sexual pleasure. That usually happens after about 3 months or so. And that's from the increase in serotonin transmission. So yeah, it's the most common complaint. And although that might be, you might think, depending on what age you are, that that could be a small trade-off for relief from severe depression. But if you think about someone in their 20s, particularly a male in their 20s and 30s, when they're really very sexually active, to be taking this drug and then have sexual dysfunction, it can really be a serious issue that needs to be addressed. So the trade-off may not be worth it, but it depends on the situation and the patient. Depression, there's no specific reason for someone to have depression. It's certainly more common if, immediate family has it, parents have it, but that doesn't mean that it's genetic or that it's inherited. It doesn't have to have an external cause or event. It can just be a chemical imbalance that happens, and it's as simple as that. So if you think about the person with severe depression, and for this you can think about someone that has situational depression if you don't know someone with the diagnosis of depression. But think about someone who's like really, really depressed. Maybe they're lying on the couch, wrapped in a blanket for days, or sleeping a lot, 12 hours a day or something like that. As a nurse, your nursing outcome will focus on the client's ability to carry out activities of daily living. So it'll be a major improvement if the person can get up and get dressed, take a shower, things like that. Those are appropriate goals for someone with major depression. If a client starts talking about some vague statements of despair, like, my partner will be better off without me, the world will be a better place without me, things like that, you have to just very clearly ask the question, are you planning on hurting yourself? Are you planning on committing suicide? Are you having thoughts to hurt yourself? There's no beating around the bush. You don't want to be vague and, tiptoe around it. You have to just come out and say it. If the person says yes, your next question is, do you have a plan? If the person says yes, ask them what the plan is. And then you have to ask, do they have the means to carry out the plan? For instance, let's say someone says, well, when I get out of the hospital, this will all be over. I'll go home and end my misery. And then let's say I say, well, are you planning on hurting yourself? Are you having thoughts to hurt yourself? And the patient says, yes, I'm I'm going to hurt myself. I would say, well, how would you do that? Do you have a plan? Yes, I'm going to overdose. I hear what you're saying. That sounds really difficult. Do you have pills saved up? What would you overdose on? Do you have pills that you've been collecting? I'm going to ask because there has to be an immediate intervention. If they say, yes, I in my bedside drawer, I have a whole bunch of pills that I've been saving up for the past 6 months, I would talk to the case manager. They would talk to the patient and try to maybe have a neighbor or family member go and get those pills. Now, you need the patient's cooperation to do that. You cannot just go into someone's house and take their property. Even if the patient says, yeah, I'm planning on shooting myself when I get home and I have a gun in my bedside drawer, you cannot just arrange for someone to go in and take their gun. That's their personal property. But you can work with the patient. Generally, the therapist will work with the patient and get them to agree to having a family member go and take the pills or take the gun and keep it until the patient is stable. Again, it's the patient's private property. We can't just take it. Hope that all makes sense. Okay, talking about therapeutic communication. When a patient is depressed and, talks about some despair, saying, I'm just so tired of feeling this way, nothing goes right for me, don't come back with something cheery and superficial. That's never helpful, and it's really condescending. It's never going to help to say, well, just look on the bright side of things, or at least you're safe here. No, you want to really acknowledge and validate what they're saying. It sounds like you're feeling really frustrated, and this sounds like a hard time for you. Is that what you're saying? So you want some clarification, you want to validate, all of those things. Don't be trite and come back with something cheerful. Okay, so another treatment for depression is electroconvulsive therapy, ECT. It's important for you to remember that ECT is a procedure that requires anesthesia. There's an anesthesiologist there and the doctor there. You don't need an operating room, but you do need a procedure room. The patient gets an IV. The patient receives anesthesia, is unconscious when they're receiving the treatment. It's a very painless, peaceful treatment, not like what you see in the movies at all. When the patient is finished, and it's very fast treatment, just a couple of minutes. I mean, the patient goes to sleep, they get a treatment, they wake up, the whole thing takes maybe a total of 5 minutes. But of course, it takes more like half an hour between the setup and the patient waking up, the patient going to sleep, the patient waking up, but the actual thing is very short. So the patient goes into a recovery area, just like any PACU after surgery you would see in the hospital, the post-anesthesia care unit. There will be an area like that after ECT, which is usually just like the room next door. And so the patient is brought next door, and they start to wake up, and we nurses are going to care for the patient like any other PACU. It's not different because it's ECT. So what are the priorities? Vital signs, maintaining a patent airway. So if the patient is very drowsy, we might turn them onto their side. Just like with any PACU, you want to make sure the patient's breathing, and you're going to treat the patient like any post-operative patient. Not that they had an operation, but they had a procedure that required anesthesia. So all post-anesthesia care, regardless of the procedure, is the same. Airway, breathing, circulation, vital signs all the time, and make sure that they're not going to throw up or anything. So turn them on their side if that's what they need. Let's see. When a patient has major depression and they're in the hospital, sometimes they're really tired and not very motivated to participate in the activities on the psych unit. So let's say you're really trying your best to convince the patient to attend group, to socialize, to come to the dining room, and they agree to come out of their room and do something. They're kind of slumping down the hall, depressed, poor eye contact, frown. You want to structure the activities so that they can complete one task at a time. You're not going to tell the patient, okay, well, it's shower time and then it's group time and then you're going to go to the cafeteria for breakfast, and you're not going to give them a long list of things. Then you got to make your bed and put your clothes away and one thing. So that'll be a win if they can do one thing. Remember, a minute ago, they were in bed not wanting to do anything. So if they've agreed to come out of bed, celebrate that win. Great, you're out of bed. That's fantastic. Let's attend morning group only. That's all you have to do. So one thing at a time. So help them complete a task. Remember that clients with major depression who are in that state in the hospital have trouble making decisions. They'll be like, oh, I don't care. And they don't want to, you can't ask them a million questions. We do make care plans for psych patients, and there are a lot of nursing diagnoses for psych patients. And risk for suicide is one, so that's going to be a really high priority. Remember, safety is generally a very high priority in general. Of course, physiologic needs are the highest priority, but if someone is about to kill themselves, that's certainly going to affect their physiologic needs, right? So remember that there is a risk for suicide nursing diagnosis that can be used, and that would take priority over the depression or hopelessness or spiritual distress. Those are all nursing diagnoses, and they're all very important. But risk for suicide is, going to be number one above those. Think about symptoms of depression. Review the symptoms of depression. Difficulty focusing, maybe increased sleep, could be decreased sleep, could be increased appetite, like weight gain, or could be weight loss. Some people don't want to eat. Anhedonia is the inability to feel joy from things. So if you hear someone say, yeah, I used to really love playing golf, that was my thing, and now it just doesn't, I just don't even care about it anymore. That's anhedonia. When your activities that used to bring you joy, you'll hear this with like cooking or arts and crafts or dancing, socializing, and the patient, just doesn't want to do that anymore. Just does not bring them joy anymore. That's anhedonia. Okay, going back to medications for major depression. People are at the highest risk for suicide about 2 weeks after starting antidepressant medication. Now, why is that? because the medication takes about 4, sometimes up to 6 weeks to start working. But after 2 weeks, it does help the patient have more energy, but it hasn't changed the brain chemistry yet. So, for the patient who was feeling hopeless and suicidal, in 2 weeks, they will still be feeling that way, and now they'll have the energy to follow through. So, when someone starts antidepressant, it's really important that they have follow up appointments in place, family support, or social support of some sort. Something has to be in place for a follow up. We're not just going to start them on medication and send them off and see them in a couple of months. You want to observe the client closely for any suicidal thoughts. Yeah, with constant assessment. All right, let's start talking about mania. So clients with mania have a lot of energy. They'll be all over the place. They'll often want to hug you. Their emotions will be going very fast. They'll be very excited. My God, I'm so glad to see you. And they're talking a mile a minute and they want to give you a hug. And it's okay for you to say, staff cannot hug patients, or I'm sorry, I'm not doing hugs today. Can we do an elbow bump instead? You can, have your response ready. Think about how will you respond to that question, because it definitely will happen. Now, there are some instances where you might give hugs. For instance, let's say you're working on a kids unit. Kids want hugs. You're not, you have to be careful with that and do hugs when other people are around. You don't want to be hugging kids in private. But we don't really do a lot of rejection of kids. But adults, it's not appropriate to be hugging all your patients. So offer an elbow bump and be clear. Staff doesn't hug patients, or we can't hug in this facility, but let's do an elbow bump, or let's do a fist bump, or something, whatever it is. Don't be defensive or angry about it. Just have your response ready. Let's see, we talked about that. So if the client with bipolar disorder or mania is getting aggressive, because again, their emotions are going to be going fast, they're going to be, really kind of high on their adrenaline. If they start getting aggressive and, attempt to hit the nurse or something, you have to be really firm with your directions. Do not hit me. If you can't control yourself, I will give you some medication to help you control yourself, or I will, we can help you control yourself by, I don't know, let's go outside and go for a walk, or let's go to the gym, or, do you need to go watch a movie or something? But you do need to be firm. Do not hit me. And if you can't control yourself, we will help you. So you have to state behavioral expectations really clearly. So if the client has mania and let's say you have to do an assessment and they're just dancing around, being really loud, being super energetic, you want to take them to a quieter place. Like maybe you would go to a conference room to talk. You're not going to talk in the corner of the day room. That's not going to be helpful. You can't talk where there's a TV. They just, won't be listening to you. If there's other things that they can pay attention to, they will. So you'll want to take them to like a conference room or some private room if you need to do an assessment or talk. So let's say it's, you know, group time or the middle of the night, and the client with mania wants to talk to you about a pass that they need to go to a doctor's appointment or something, and they're really focused on this, and that's all they want to talk about, and they want to work it out right now. When am I going to get this pass? Am I getting the pass? Did you see the pass in my chart? I need the pass. Will you double check there's a pass? Can you call the doctor? They're talking a mile a minute. They're really focused on this pass. You will have to, just like above, be really clear in behavioral expectations. I'm not calling the doctor right now, but let's you and I talk about the past. You can't just tell them, I'm not talking to you, and stop talking about the past. That's not going to work. They'll start getting agitated. But you can say, I'm not calling the doctor about the past right now. We can call the doctor at 9 in the morning, or talk to the doctor when the doctor's here tomorrow. And let's you and I talk about the past. What are you going to do with it? And tell me about the appointment you have to go to. So, validate the client's concerns while setting behavioral limitations. Very often with clients with bipolar disorder, they will take lithium and an antipsychotic. They work together to provide a more rapid control of manic symptoms. And your outcome will be minimal mood swings. Remember that with psychiatric disorders, we're not curing them. They're not going to be 100% gone, but a reasonable outcome will be control of symptoms or minimal symptoms. So there might still be mood swings, but it'll be minimal mood swings, not the extreme mood swings that get in the way of having a functional life, like working or having a relationship. There can be minimal mood swings. I have a friend with bipolar disorder who's a lawyer, very productive, excellent lawyer, very productive person, a parent, and sometimes she does get mood swings, sometimes she gets mania, but it's at such a minimal because she really stays on top of her meds and sees her doctor frequently. So it's not ever going to go away, but you absolutely can control the symptoms so that the patient can get on with life. Again, if you want to talk to a patient that has mania, you want to decrease the environmental stimuli. So those, could start getting agitated and have increased mania if the TV's really loud or the music's really loud or the unit's really crowded. Maybe there's a lot of patients and they're moving all over and talking loudly and there's a lot of commotion. The person with mania will not do well in that environment. And so if someone is asking you a million questions, just kind of rapid firing those questions, you can say, please slow down. Let me figure out what you need first. What can I do for you first? Because they'll ask you 20 things at once. When someone is on lithium, remember lithium is a salt. And what follows salt? Water. So salt and water very closely related in the body. Where salt goes, water goes, and vice versa. So the person on lithium, in order to keep a stable lithium level, has to also keep a stable level of fluid. What that means is no excessive sweating. They'll get really dehydrated. They cannot have excessive water intake. And what I mean in that case is a rapid change in their intake of water. So let's say someone typically drinks 6 glasses of water a day. And they say, well, you know what, I'm going to drink more water and I'm going to double that. you have to caution them not to make that kind of change in their water intake. Or if they are going to make that type of change, that means they have to come in more frequently to check their lithium level, because it will affect their lithium level. So you want the person to drink decaffeinated fluid. Caffeine is dehydrating. You don't want them to really make extreme dietary changes, especially in their salt intake. And they need to see the doctor if they get sick, if they get the flu, if they get a stomach bug, because they'll be losing a lot of water, right? If they have a fever, they might be sweating. They have a stomach bug, they might be throwing up or having diarrhea. All of those things cause fluid loss. So we want to keep the fluid level stable, fluid intake and output, keep it stable. So if someone on lithium says, you know what, I'm going to run a marathon next month, you know to schedule their lithium levels around that, because they'll be obviously sweating a lot for that activity. Okay, I'm gonna stop the video there and start a new video for the last couple of topics.